Ladies and gentlemen, dear colleagues, I'm Dr. Giancarlo Marra from the University of Turin. We are here at the EAU 26 Congress in London, in the UK, which is, as you know, the largest urological event of the year in Europe. And today I have the pleasure to welcome here Professor Derya Tilki and Professor Phil Cornford, who are respectively Vice Chair and Chair of the EAU Guidelines panel on prostate cancer. And as EuroOnco platform, we will discuss what are the changes in the guidelines this year. So compared to last year, where some, I would say, major changes happened, this year there are a bit less change that we will discuss within the interview. So I would start with localized disease. Derya, what do you think are the change it is worth mentioning and our colleagues should know about this year edition?
Yeah, thank you very much for the opportunity to highlight the changes. You said it very correctly. There actually haven't been that major changes this year. Last year we had changed the EAU risk groupings, where we subdivided the intermediate risk grouping into favorable and unfavorable intermediate risk, similar to the NCCN guidelines. This year we slightly updated it again to be more conform with the Cambridge risk groups, which have been also validated for a mortality endpoint. Another important change is also our recommendations for high-risk BCR according to the EMBARC data. There was an update presented on overall survival at ESMO this year, and we saw the impressive overall survival advantage in the patients receiving enzalutamide plus ADT, but this overall survival was not seen in patients with enzalutamide monotherapy. That's why that recommendation has changed to enzalutamide plus ADT instead of plus minus ADT. So those are some of the changes.
Okay, so the overall survival data make you change in terms of ENZA and ADT.
ENZA monotherapy wasn't a recommendation.
And concerning diagnostic, I had a look at the guidelines and I saw you added a section on micro-ultrasound based on the Optima trial. Do you want to give us some insight on?
Yeah, correct.
This?
So we. In general, we added some new sections in the text, but sometimes didn't do a recommendation for that where there's not so much data out there. The trial looked at a biopsy strategy with micro-ultrasound, which instead of MRI, and also one arm with a combination of micro-ultrasound and MRI, and showed that it wasn't inferior to the MRI fusion biopsy. The detection rates of significant prostate cancer, but it is a study which is in high volume centers it was done, and not many centers have micro-ultrasound available yet, so there has to be more numbers and more validations until there can be a clear recommendation. So at this moment we don't have a recommendation to use micro-ultrasound in general.
Okay, so the signal from the trial is good, but resource availability is another issues that needs further evidence. And I saw compared to Optima, you didn't refer to the NeuroSAFE trial within the guidelines. Is that correct?
Yeah. No, actually, we also have a text part for the NeuroProof study, which was published also last year. A study from the UK. Randomizing patients to the NeuroSAFE frozen section technique versus MRI approach to decide about nerve sparing. As you maybe know, the NeuroSAFE was developed in the Martini Clinic.
Yeah.
It needs a lot of resources to really be able to do the NeuroSAFE frozen section. It sometimes adds, and in the study also, about 40 minutes to the procedure, and not every center can also have the pathologists who are able to give that much resources to it. Also, Although it has shown a slightly better erectile function in the patients in the NeuroSAFE group and also better early continence, there has been some signals that there might be more recurrences, but that data is not mature yet. And therefore, we have not, for all these reasons I mentioned, we didn't do a recommendation that this has to be used.
So again, another interesting technology that has to have a bit more applicability and it is not that straightforward.
In that case, I don't think there will be a recommendation later on. Right?
I mean, I don't think that the functional results were quite as impressive as people hoped they would be, and you might have accepted the slightly increased risks that came with it if the functional results were really stunning.
Astonishing, exactly.
But although in statistical terms there was an improvement, in actual clinical practice, whether that is a big enough difference to make a difference was also just a bit of a question. If you were the man and you moved from 9 to 12 on your impotence score, did that really make a difference?
Yeah, of course, it's important all the time to stress the difference between statistical significance and clinical significance, and this was a good example.
And one more thing on that study, basically there was much more obviously nerve sparing rate in the NeuroSAFE group, so it could also mean that patients who were in the MRI standard group to decide about nerve sparing, that was too strict regimen on nerve sparing. So you could also increase your nerve sparing rate if you adapt that MRI approach. It doesn't have to be a frozen section.
Yeah, of course. This is another thing. We see higher and higher rates of nerve sparing, especially in high-risk disease, which just a few years ago was not the candidate for nerve sparing at all. So.
Exactly.
Okay, thank you very much. And I think we can move on to metastatic disease. Philip, there have been some changes also in this section. Again, not major, but would you like to tell us about what is worth mentioning and highlighting?
So I think the really interesting data that came out last year was the combination data for BRCA patients in metastatic hormone-sensitive. The Amplitude study suggested that the combination of niraparib and abiraterone had an improved radiographic progression survival. It's not yet a mature study, but we are now suggesting that people should have BRCA testing before when they present with high volume metastatic disease, because I think that there will be an option to use combination treatment for people who present with metastatic hormone sensitive. At the moment, that license isn't available, but it clearly will be coming down the line, and a bit that's a signal of the direction of travel rather than quite a firm recommendation at the moment. That's where we're up to. But again, I think there's a lot of interest for people presenting with metastatic hormone-sensitive disease about trying to provide personalised treatment. There was a lot of interest last year in PTEN and the Capitello study. And again, there's a section in the guidelines all about that. And hopefully that helps people understand why we didn't give that a positive recommendation at this stage. The data shows, again, no overall survival benefit. Again, the data is not mature. It was only an interim analysis. But it's really interesting to think how we can take those people who have poor prognosis, identify specific abnormalities, and then target their treatment. And I think for the PTEN, the other thing that was discussed quite a lot and is in the text of the guidelines, but not in a recommendation particularly, is the role of docetaxel. We think that probably those people with PTEN loss have a greater sensitivity to docetaxel. It might be an indication for triple therapy for people who've got PTEN loss, and they certainly do very badly with ARTA plus ADT as doublet therapy. So I think that's really where the biggest change for metastatic disease was.
Okay, so we are moving again towards personalized medicine in terms of localized disease, but now also in terms of metastatic disease, and studies from castration-resistant prostate cancer show how important it is to have noticed this alteration, and now all this info is now applying and moving towards the hormone-sensitive setting. And I noticed another interesting part that has been added is the recommendations and suggestions in terms of what comes with ADT and systemic treatment in terms of support for patient. Can you also give us some insights on this?
So, of course, because we're getting more effective at treating people with metastatic hormone-sensitive prostate cancer, they're living longer. And now they have to deal with the sequelae of all those treatments for much longer. And so things like osteoporosis, we saw that combination of enzalutamide plus ADT. If you don't give a bisphosphonate, you're going to run into significant risk of osteoporotic fracture within the first 12 months. And so now the recommendations are suggesting that you must do something about bone protection early on. We might need to think about metabolic syndrome. We might need to consider treatments for cardiovascular risk. And those treatments, which used to just be part of what we did for cardiovascular disease when that's where those drugs were mainly used, have all been brought forward into the hormone sensitive. And I think it's really important because it's a low-cost way of improving outcomes for patients by adding in a bisphosphonate when you use combination treatments.
Yeah, I think this is a very important aspect because sometimes it's obvious, but I think it's something that maybe also improves overall survival for some patients, because typically prostate cancer is a disease of an older patient. So an older patient, if he's going to fall down and maybe he's going to have a fracture because you didn't bisphosphonates, he's going to stay in bed for 3 months, and who knows what can happen in an 8 years old having these issues. So
50% of people who have a hip fracture die within a year. It's a really bad outcome, and so on that basis, it's very important that we do all we can to try and prevent significant osteoporotic fractures. And also, they're painful, aren't they? If you have a patient and they have a lumbar fracture as a consequence of their combination treatment, they get awful back pain, they're very worried that that's the cancer progressing, despite the fact they're BRCA. You do lots of tests in order to try and prove it, and they've still got weeks and months of pain while that settles. And so with patients at the centre, we need to ensure that we manage the predictable complications of the treatments we're giving.
yeah, I think it's very important to have this as well in the guidance. 10 years ago, we were prescribing ADT and maybe not thinking at all about this aspect, whereas now they are central. And
they didn't live that long 10 years ago. That was the point, wasn't it? Now treatments allow them to live much longer, and therefore the incidence of these things are going to get more common because people are going to live longer. Average life expectancy is somewhere between 7-8 years for people presenting with metastatic disease, at least in the UK.
Okay, thank you very much. It was very nice to have you and to have an update about this year guidelines. I think we may see each other next year for next year changes. And thank you very much to everyone for listening.